The following presentation is a recorded event hosted by the Nutrition and Aging Resource Center on February 8th, 2022.
My name is Alex. I'm the director of the Nutrition and Aging Resource Center, a cooperative agreement with the Administration for Community Living. This is the Nutrition and Aging Resource Center website. So it's acl.gov/senior nutrition. So there's a lot of great resources and tools. There will be a redesign of the website soon. So if you're having troubles finding any resources, please feel free to reach out. We have our website here that you can subscribe to our newsletter. And we also have a calendar of events where all our webinars are posted. So you can register right on here. And all of these links are included in the chat. If you scroll up to the top, you can see all of them there. And you can subscribe right here at this button. This is our Facebook page. We are on Facebook, YouTube, Instagram, LinkedIn, Pinterest, and even TikTok. So all at Aging Nutrition. There's a lot of great information about some graphics that you can share, or you can learn about what's current and upcoming for the Nutrition and Aging Resource Center. This is our YouTube channel. All of our webinar recordings are located on here. So this one is being recorded and will be uploaded to YouTube. We also have the research grant opportunity for the 2022 Innovations Nutrition Programs and Services grant located there. So we recommend you check that out if you're interested in the research grant. So back to our website. We made it really easy for you. You can click on this link right here and it will bring you to these new grant opportunities. Have it pulled up. We have the Replication grant, which we're talking about today, and the research grant. So you can see right here that there are 4 replication model toolkits available. And I will click the link and it's this page. So there's a lot of toolkits available about these replication models. There's A, B, C, and D. Okay. And if you click on this link, this will bring you to grants.gov, which is where you'll find all the information and details to apply for the grant application. This is the synopsis. Applications are due March 10th. You go to related documents. There is the full announcement there, as well as the FAQ page. Inside the full announcement, you'll notice that there's an informational call tomorrow with ACL at 2 p.m. Eastern time, included the dial-in information in the chat where you can ask more technical questions. And with that, I will turn it back over to Erin.
Thank you so much, Alex. So we are going to go ahead and get started again. We are, okay, how to get to my right side here. Just a few housekeeping items. Please keep yourselves on mute. If you're like me, apparently you can't get off of mute, but that's okay, because you can use the chat function at any time. If you want to use closed captioning, at the bottom menu, the third from the right should be a little CC with the live transcript. And if you could benefit from that, that may be helpful as well. Now I'm going to present our next speakers. So we have LaTanya Clark from the Maryland Department of Aging and Livleen Gill she's the CEO and president of BNWS. And they will be talking about addressing malnutrition in community living, older adults. So I will just let you both know when you need me to advance slides. Let me know and I can do so for you.
Thank you very much, and thank you for having us today and giving us this opportunity to share about the Malnutrition Toolkit. So I just want to talk about why it is that we applied. You can't tell if a person has malnutrition simply by looking at them. And malnutrition is a hidden condition in the body. And we know that diet directly impacts our overall health. And as the systems of the body decline with age, it can lead to poor appetites, changes in their taste buds, chronic disease problems, chewing, swallowing. These are just a few of the items that they contend with. Older adults are at higher risk for malnutrition because they already have other risk factors also, such as limited income, dementia, depression, and one of the biggest ones right now during the pandemic is social isolation. So the gaps in addressing our community-based settings, malnutrition increases healthcare costs. Malnourished patients are patients with documented longer stays in hospitals, higher costs, and in-hospital complications. And hospitals can only provide short-term interventions, and they don't address the social determinants of health. Poor health can be traced back to your economic situation, the neighborhood you live in, your access to health care, your education, and your social standing in the community, your social community involvement. So the aging network is able to impact malnutrition through providing services that address the social determinants of health. The aging network staff, they know their clients well, they develop person-centered approaches, and they're best suited for identifying malnutrition risk. As I stated, you cannot tell if a person is malnourished simply by looking at them. And malnourishment is more common than we realize, and it really does place our older adults at significant risk for illness, for falls, and for poor quality of life. And it often goes undetected. The relationship that the aging networks build with their clients can help identify these risk factors in their community, which can prevent some of these harmful outcomes. Next slide. So screening should have mechanisms to notify the person's healthcare provider in order to facilitate the healthcare providers ordering of further tests, referral to specialists, and any other therapies that they might need. They should communicate with the community-based interventions, which both allow them to have your organization's impact and potentially secure your relationship with the community. Gives you an opportunity to secure funding. It allows for effective clinical approaches to addressing the illnesses. AAA should also consider partnering with healthcare organizations to gain access to other resources such as funding, staff and training opportunities, enhanced quality assurance of current and new programs, increased cost effectiveness of some of the existing programs, opportunities to increase the number and types of services that you can provide, improve technology and documentation of service delivery, and expanded options to appropriately assist older adults. All of this can have an improved health and quality of our clients. And healthcare organizations also have monetary incentives for partnering with our local community-based agencies. And this implementation and partnership can have a high quality effect so that the AAAs can therefore assist and help reducing healthcare costs. So I'm going to now turn it over to Livleen, and she'll walk you through the process.
Hello, everyone. I am really excited to be here. And one of the things, you all work in Area Agency on Aging in elder care. This was our first work that we did in this arena with the Maryland Department of Aging. And it was an absolute joy and privilege to work on this ACL grant with the Maryland Department of Aging. Next slide, please. So the malnutrition pathway, there are three components: the screening, referrals to address root cause, and the third, monitoring client progress. We are all living for the almost 3 years now in the era of COVID, that I call it, right? It is, if malnutrition and screening for malnutrition and addressing it was important before COVID, it is even more important. I don't know if any of you have looked at what the National Resource Center sent out in their February newsletter about malnutrition in older adults, a recent study that has been done during COVID. It is an absolutely excellent study that everybody should take a look at it if you're planning to apply for this replication grant. Next slide, please. The Area Agency on Aging already provide a wide variety of services for adults, right? From in-home care, care management, home-delivered meals, transportation, prevention of elder abuse and neglect, and a lot of evidence-based programs. Well, tackling malnutrition is not a matter of making changes to these programs and services, but instead think about how to most effectively screen and refer to these programs. What is screening? Well, screening is a process of determining if there may be a problem. And screening differs from assessment and diagnosis, which only medical experts can do an assessment and diagnosis. But screening can be done just using validated tools by laypersons who are trained. And why validated tools? Because validated tools have been tested for reliability, validity, and sensitivity. So the data that we are getting is what we are going to use it for, and it's sensitive to what we are collecting. Now, the choice of screening tools utilized may depend on the Area Agency on Aging's fiscal resources, your staff time, training and preferences, coordination with existing AAA databases, and the availability of programs that you have. There is no one size fits all. As the earlier presenter said, how they went about laying out the groundwork for this was based on the resources they had, and whatever they thought in the beginning, it changed. So just be mindful of that when you are looking at how you may replicate this. The area agencies in Maryland are required by Medicaid to screen the clients for long-term services and support with a level 1 screen. Some of the home-delivered meals with a determined checklist. There are a number of validated malnutrition screening tools. The MST, which is the malnutrition screening tool, one of them. It's quick and easy. It has 2 questions. And one area agency on aging in Maryland, MAC Incorporated, uses this, and we have it in our toolkit. Should a positive screen occur, AAAs need to establish a process to notify the person's healthcare provider and communicate with them any community-based interventions that the individual may need and may be securing from your agency or another community-based organization. Next slide, please. To effectively address the root or the causes of the underlying malnutrition, and to allow an individual to improve their mental and physical health, person-centered screening, referrals to programs and services, and eligibility counseling should take place. Now, one of the programs, Stepping Up Your Nutrition, is an evidence-based workshop that many of the Area Agency on Aging may be utilizing. Participants, they identify their own potential nutrition risk status and establish their own goals to improve their nutritional status. Step Up Your Nutrition could be an appropriate referral for an individual with malnutrition, or it could help identify a root cause for an individual who was referred for falls. So it just depends on what we're trying to get. Now, in addition, Area Agency on Aging can provide nutrition counseling and education, meal provision and delivery. Those are others. In 2019, under the auspices of this grant, Maryland Department of Aging and Bethesda Nutrition and Wellness came up with shelf-stable, medically tailored meal packages, which were provided to those individuals that were identified as at risk for malnutrition by the hospital discharge planners, and they were sent home with these shelf-stable meals. The Area Agency on Aging could provide them the additional nutrition counseling and education. Those meals were also delivered to individuals if they couldn't come to the transitional care clinic. They were delivered by community health workers if the hospitals utilized them. And this program identified malnutrition, but also what it did was it decreased the utilization of healthcare by almost 50% by those individuals that had been identified for malnutrition. Next slide, please. Now, monitoring the client progress and service quality. This is ongoing to monitor the client progress. You all make care plans, those care plans, and you rescreen the individuals, whether they need additional services or they are benefiting from your services. We have in our toolkit a care plan template that can be used. Care plans can be done or revised every 30, 60, 90 days. That is up to whatever patient-centered way that you would like. Now, for quality assurance, what we measure, you can measure client satisfaction, compliance rate, utilization. These are some of the items for our meals and for our program that we did measure with the hospital. In terms of the meals that we had provided, there were dietary adjustments. There were high protein, high calorie meals. There were carb control. There were low sodium and heart healthy. Now, one of the things when we started the program, when we were developing the menus for these medically tailored meals, the hospitals thought that their need was going to be more in the heart healthy. It turned out that that was not the case. The need for the carb controlled menus were actually higher than any one of the others that they had access to. These were sourced by us. However, the actual kits were put together based on the menu by Maryland Food Bank, which was one of the other contractors on this, and then they delivered those to the hospital or to other areas that was needed. In Appendix 6 of our toolkit, you'll find the QA resources that people can use, and these can be tailored to what your needs are for your program, what you would be doing. It doesn't necessarily have to be exactly what we provided, but that may be a starting point for. Next slide, please. So sustainability is always a big thing. What did we do? Was our program sustainable? I'm here to say that yes, what we learned during 2019 when this program ended, and as you all know, COVID struck in March of 2020 when congregate dining shut down and all of the Area Agency on Aging had to relook at how they were going to get meals to individuals. At that time, because we had these menus already made, we were approached by Area Agency on Aging to provide these meals, these medically tailored meals based on the standards, which we were able to do not only in Maryland, but in Delaware and in DC. And we continue to work on providing these. The second thing that came out was a collaborative partnership between one of the AAAs, which is the Carroll County in our area, and the hospital system. we got them introduced to each other and to show that, to highlight the services that the area agency provided. The hospital system was interested. In the first 6 months, they were just looking at seeing how they could work this. Today, there's a partnership where the AAA has a paid individual that the hospital pays for, is embedded in the hospital, but works and gets the referrals and everything set up. And this way, they were telling me that they have been able to provide more services, and the utilization, the bouncing back to the hospital for these individuals has really come down. So looking at it, that has been an incredible partnership and what we've come out of from this grant. So I'm really happy to say that this malnutrition replication, if somebody is interested in, it is a really great toolkit to be able to replicate. That is all I have. Thank you.
Excellent. Thank you so much. Really appreciate all the information. I do have some questions already. So one of the questions is actually, I think, more for us here at the Nutrition and Aging Resource Center. And that was, are nonprofits eligible to apply? So making the assumption that you're asking about the nonprofits applying for these grants, this information is all located in the grant.gov grant page. So anytime you have any questions like that, that's also a really good place to check, but I'm going to read you off what it says there. So it says eligible applicants are those that are special district governments, independent school districts, Native American tribal organizations other than federally recognized tribal governments, state governments, Native American tribal governments that are federally recognized, public housing authorities, Indian housing authorities, nonprofits having a 501c3 status with the IRS, other than institutions of higher education, county governments, city or township governments, public and state controlled institutions of higher education, and private institutions of higher education. Whew, that was a mouthful. So thank you so much for bearing with that. Now, the next question is for our presenters, and that is, did you use a company for the shelf stable needs?
Terry, do you want me to answer that?
I was going to say, yeah, you can go ahead and answer it since your company's the one who did it.
Yes. Bethesda Nutrition and Wellness Solution is the company that did the shelf-stable meals and continues to provide medically tailored shelf-stable meals.
Excellent, thank you. And forgive us here, we're not sure, but which malnutrition screening was used? I know you had mentioned several, but which did you use for your project in particular?
So the 2-question screening that I referred to, that one of the pilots where we used it, it was the MST. That was what was used, but you could also use determine. I mean, it really depends on how you want to use it and what you're trying to get out of it, what your staffing is, and how in the work process you'll be able to kind of utilize it.
Excellent, thank you. So next question, could you say a little bit more about the partnership in which a hospital paid for a staff position at the AAA and it lowered hospital utilization rates? Is this included in the toolkit, and is the toolkit available? This model is of interest.
So the toolkit is definitely available. At the time of this grant, we, the Maryland Department of Aging, and us, we made the connection for the Area Agency on Aging and the hospital system. So Bethesda Nutrition and Wellness is a care transformation organization in the Maryland Primary Care program. So that's kind of how we were able to leverage the healthcare side to be able to connect the local area agency on aging. It's only so since that time, and that this is not in the toolkit, since that time, That happened in 2019. And remember, COVID hit in 2020. They were in the initial stages of it. In May of 2020, what they did was the AAA paid 30% of the salary for this individual, and the hospital paid the rest. The new contract that started this year, the hospital is paying 100% of that individual salary. Now, remember one thing, healthcare is not going to pay for an individual salary if they did not see the return on investment for what they pay. And they did see the return on investment, and that's kind of why it is. And now they're in conversation, maybe there'll be another 0.25 person that they would be able to hire. So those partnerships are critical. That utilization rate, if you can show that it decreases utilization of healthcare and the cost by working with you, that is really the key to coming up with a partnership with the healthcare entity.
Excellent, thank you. And could you remind us quickly where that malnutrition toolkit can be found?
I think it should be on the ACL website. That's where it was the last time I saw it.
Okay, excellent, thank you. What was the customer satisfaction like with the shelf-stable meals? What type of feedback did you get that was actionable, and did you use that to improve the meals?
Great question. So the saddest, I don't have the figures. I remember that the client satisfaction, the surveys that we did were between 88 and 89% of our shelf-stable meals. What they liked was ease of opening them up and mixing. There wasn't a whole lot of preparation. All it requires is either hot water, or if you have a microwave. They were single serving so that they would be, you don't have to do too much mixing, and especially if you've just been discharged from the hospital, you don't have to think about it. The menu was there, and it gave the instructions how to put it together. So you knew exactly what you were going to be eating. And we also had to do it in the sense that if somebody was in a shelter or homeless, that they would be able to utilize these meals easily. So it didn't require a whole lot of preparation. And we stayed away from, words like cook, because cook, for somebody, that word brings up a whole lot of that. It requires a lot of preparation. So kind of how we did that. And I don't think that's in the toolkit, but I'm happy to share kind of how we put that menu together and the instructions.
Excellent, thank you. And it looks like we have about a minute left. And so one last question. Would you happen to have the title of the position that was funded? I believe this is in regard to that position at the hospital.
It was a position for MAP. And Tammy, you can probably elaborate on what that stands for.
The Maryland Access Point.
Excellent,
It's
thank
what
you.
MAP is. Mm-hmm.
Well, thank you so much. We are at time. So a lot of great information there, a lot of great questions answered. So we are going to go ahead and move to our next speaker.